Well, it's a pleasure to be here today and to come across the pond. We're one of the original 13 colonies, and Charleston is a great place to visit. If you haven't been there, I would encourage you to come visit. As Donna said, I do have a few conflicts. I've had an opportunity to write a few books on the subject, and I have 2 kids in college, so if you haven't bought one, please feel free to. It will help out immensely. So what are my objectives today? My objectives are simple. We're going to discuss the Society of Cardiovascular and the American Society of Echocardiography, both basic and advanced perioperative guidelines. And we're going to discuss the kind of the views that we elicited for both of those guidelines and kind of go through that. And hopefully this will be a review for most of you and not something relatively entirely new. So let's start with the basic guidelines and how we came about the whole concept of basic. So the American Society of Echocardiography has something called the Intraoperative Council. And the Intraoperative Council is a group of people who basically live in the perioperative space in echo, and it's a collection of cardiologists, cardiothoracic surgeons, and cardiothoracic anesthesiologists. And around 2012, 2013, we thought there was a big push by the American Society of Anesthesiology to develop a basic concept. And so we thought, well, if we're going to do that, well, maybe we should have some kind of guidelines around basic echocardiography, what it is, and specifically what it is not. And I want to spend a fair amount of time tomorrow kind of going through that particular document. But again, it's predominantly, try this again here. Okay. Hold on just a second. I got computer malfunction up here. All right. So, sorry. Colin, you any good at this? It's kind of like all of a sudden froze.
Maybe just Skype this out.
Okay, try it again. Yeah, I think it's probably me. Okay.
They've been having trouble as well.
Yeah. Okay, so anyway, sorry. David Adams is a cardiac sonographer at the Brigham's. Jennifer Walker was a cardiothoracic surgeon at Mass General who was on the project. And then the rest of us were anesthesiologists. And what we did is we went back and looked at the training and certification discussion that had occurred about a decade earlier. So Michael Cahalan, who most of us will realize is probably one of the founders of perioperative ultrasound echocardiography, originally from UCSF, and is currently the chairman at the University of Utah. Back in 2002, came out with training objectives and the number of required transoesophageal echocardiographic examinations that were needed to be both kind of a basic or advanced certified. And this is a table that came out of his manuscript. And you can see that there were 150 examinations needed for basic certification, of which 50 were personally performed. And then as far as advanced, it was 300 for advanced, as 150 personally performed. And so a lot happened. So we developed training guidelines across the globe for advanced perioperative echocardiography. So for North America, the National Board of Echocardiography was formed. EACTA created advanced certification over in Europe. It's a Japanese society developed in Asia, etc. All around advanced, but nothing was occurring in basic until around 2013 when the ASA asked us to start certifying people in basic echocardiography. And these are, so again, what is basic? There's knowledge that needs to be transmitted about the principles of echo, how to handle the equipment, how to evaluate the valves, etc. And then technical skills, the ability to actually manipulate the images, to recognize pathology, etc. So we know we need to do 150 exams. That's been published since 2002. But what views would encompass a basic examination process. And so what we did is we went back to the comprehensive document that Jack Chainwise led. Jack is at Columbia Presbyterian in New York, and it was published back in 1999. And so if you remember, there were 20 views that made up the advanced comprehensive examination. And so from those 20 views, we developed a guideline paper, a consensus paper, again from the SCA and the American Society of Echocardiography, defining what we thought a basic examination was. And I had the pleasure of leading that effort, and we came up with 11 views. So we thought these were the essential views that needed to be done on every patient to have a basic component to it. Now, we also felt that if you were doing a basic exam, you needed to have the ability to also do a comprehensive exam in case you needed to consult an advanced echocardiography provider. So kind of concurrent with that, again, as we got involved in looking at the basic concept, realizing that the 1999 advanced paper was getting kind of old. It was, 20 plus years old at the time. The same group got together and decided to revise the comprehensive document. And so Rebecca Hahn, as a very prominent interventional cardiologist, echocardiographer in New York, she led the effort. And again, I had the opportunity to sit on this illustrious panel. And this group was predominantly made up of cardiologists with a few cardiothoracic anesthesiologists and sonographers. And we came out with this very nice table that was designed actually as a marketing scheme. So the American Society of Echocardiography wanted to have something that they could create as a beautiful poster that you could put in your labs and in your operating rooms. And so this is kind of what came out of the manuscript. But we went from 20 views to 28 views. And so in a minute, we're going to hear a lecture on what happens with echo in the interventional suite, and a lot of the views that were added were views specifically tailored around what the cardiologists were doing in the cath lab for occluder devices, for such things as the left atrial appendage, etc. So let's spend the next few minutes and kind of go through both the basic and advanced perioperative guidelines that have been developed. And we're going to start off very simple with image orientation. I know we have at least one medical student in the room. And so just remember that when you advance the probe, when you push in or pull out, we call that advancing the probe is pushing in, withdrawing the probe is pulling out, excuse me. We can turn the probe manually. We can turn it to the left or turn it to the right. We can flex the probe. If we flex it anterior, that's called antiflex. If we flex it posterior, that's called retroflex. And then with a little knob, we can actually turn the transducer itself either left or right. And again, there's four main imaging planes that we're going to be looking at: the upper esophagus, you can see here, the mid-esophagus, transgastric, and in deep transgastric views. So one of the things that we wanted to fix when we decided to do the comprehensive revision was we wanted to add Mr. ME 5-chamber view. So I think from the beginning, back in 1999, the day after the paper was published, everybody in our field goes, hey, where's the mid-esophageal 5-chamber view? It was not included on the initial document. So that was one of the first things that we wanted to fix. And the nice thing about this view, as you all know, is that we see the left ventricular outflow tract and we see the aortic valve. And I think most of us probably start our examination somewhere around the mid-esophageal 5-chamber view. So we're going to have the picture-in-a-picture here that's showing the omniplane angle in the corner. We're going to have the depth of the probe with the beam of the ultrasound demonstrated here on the right. And any of the images that look like this are part of the comprehensive exam. So then the next view from there, we're going to push the probe in just a little bit, advance the probe, and we're going to get the ME 4-chamber view. When you don't see those little picture-in-a-pictures like I showed on the previous slide, this is one of the views that's actually part of the basic exam. And so this is how I tried to differentiate in my talk what was part of the basic examination. It's just a slight differentiation on how it's being presented. But all the views are part of the comprehensive, the 28 views of the comprehensive exam. So by advancing the probe, now we see more of the mitral valve. The left ventricular outflow tract is now going out of view, etc. With slight rotation of the probe to approximately 90 degrees, now we're going to see the mitral commissural view where we have P1, P3, and A2 in the middle. Again, notice that as we rotate the plane, we're going to get a more perpendicular type beam orientation. Further rotation of the beam of the angle is going to give us the mid-esophageal two-chamber view. We're going to start seeing the left atrial appendage, the circumflex coronary artery, the coronary sinus typically comes into view with the ME two-chamber view. Further rotation of the angle, again, now is going to give us the mid-esophageal long axis view. This patient has a VAD in, and we'll start seeing part of the sinus of Valsalva. We're going to see the right coronary cusp in either the left or non-coronary cusp up top. Slight further rotation and withdrawing the probe just slightly, it's going to give us the mid-esophageal aortic valve long axis view. Now we'll see more of the coronary ostium as well as the proximal aortic root. And then further withdrawing the probe gives us this nice tubular structure where we see even more of the proximal aortic root, typically zone 1 and zone 2 of the aorta. And notice that the aorta is going to be in long axis, whereas the pulmonary artery will be in short axis in this view. And we just did it by just rotating the plane 90 degrees from the view that we had previously. Or, excuse me, pulling out. We're going to rotate 90 degrees now, and we're going to get the short axis of the plane that we just saw, where now the pulmonary artery is going to be in long axis, and the aorta is going to be in short axis. You can see a pulmonary artery catheter in this particular patient. Pushing in a little bit and maybe changing angle just a little bit will give us the aortic valve short axis view, and now we're going to be able to evaluate the three cusps of the aortic valve. See the coronary arteries coming off as well. Pushing in just a little bit more from that view will now give us the RV inflow-outflow view. Again, this is one of the images of the basic examination as well as the comprehensive examination. Now we're going to go a little bit back to zero, pull out a little bit, and we're going to get the modified bicable view. This is a new view, and it allows for better evaluation of the tricuspid valve, especially the short septal leaflet. So you'll see the septal leaflet in this view of the tricuspid valve. By withdrawing slightly from that view and a little bit further rotation, you'll get the mid-ME bicable view. You'll see Christi terminalis, superior vena cava, inferior vena cava, etc. Now, by going back to zero from that view, we're going to get the mid-esophageal right pulmonary vein view. Again, a new view, and the importance of this is that the inflow of the inferior pulmonary vein seen here is typically going to be perpendicular to the beam, whereas the superior pulmonary vein will be parallel to the beam. And so this is a view that we're going to use a lot if you do congenital surgery, specifically around sinus venosus, VSDs. You're going to spend a lot of time looking at anomalous pulmonary venous return, etc., and you're going to really want to concentrate on this view. Now this is the exact same view, but I have a slightly different nomenclature to it. And so from that same view, if you take the probe and you actually turn it to the patient's left, you're going to get the left pulmonary veins are not shown in this particular image, but that's how you would get the left pulmonary veins from the upper esophageal right view. Another new view that we added this in the comprehensive document is the mid-esophageal left atrial appendage view. And so again, it's slightly more rotation on the omniplane than the two-chamber view that I showed you before, and zooming in, the depth is changed in order to spend more, or to concentrate more on the left atrial appendage. Get the transgastric basal view now. Now we're going to leave the mid-esophageal views and push down further into the stomach to get the transgastric basal short axis view. You get to see a nice mitral valve leaflets here. And then pushing in a little bit further, you're going to get the transgastric mid-papillary short axis view. This is the view that we typically use in anesthesia, the bouncing donut, to evaluate ventricular filling. And then pushing in even further, now we're going to get the transgastric apical SAX view, where we can actually see the left ventricular apical cap. And if we took the probe and turned it to the patient's right, we would also see the right ventricular apex. And so this is going to allow for evaluation of the apical segments of both the right and the left ventricle. So we turn toward the right a little bit. Now we're going to see the transgastric right basal view. And the transgastric right inflow-outflow view. It's just fine manipulation of the depth of the probe will allow you to see both of these views. And sometimes you have to change the angle just a little bit from 0 to get the RV inflow-outflow view. So from the transgastric RV basal view, it's going to take maximum right flexion results in opening of this view. And you can see the anterior and posterior leaflets of the tricuspid valve are actually seen well on this view, as well as the left and right cusp of the pulmonic valve. Further rotation from that view will give the transgastric two-chamber view. And even further rotation now will give the transgastric long axis view, where you get to actually see the part of the aorta and the aortic valve. And this is a view that you'll use for Doppler interrogation of the aortic valve. And then pushing the probe in even further and extreme anteflexion will give the transgastric five-chamber view, where you have the aortic valve, mitral valve, and aortic root. Again, probably the primary view that we use for evaluating flow across the aortic valve. So now we're going to turn the probe completely posterior and look at the aorta. We're going to start with the descending aorta short axis view. Again, at 0 degrees, and then 90-degree rotation, we're going to get the descending aortic long axis view. And so typically what we do is that we start in the short axis, pull all the way up until we get to the arch, and then go to 90 degrees and push all the way down, looking for atheromas, aortic dissections, etc. So when we pull all the way up, we're going to get the aortic arch long axis view, and then rotating 90 degrees from that, now we have the aortic arch and short axis. You can see some calcification in this particular aorta, as well as the pulmonary artery and the pulmonic valve. All right, so that's the comprehensive exam, as well as showing the basic components. And so there were some specific indications that we felt were useful for basic perioperative echocardiography, and they're kind of listed here. I'm just going to run through them quickly and give you some rationale behind the writing group and why we thought these views were important. And the first one is looking for global left ventricular function. It was a recommendation of the writing committee that somebody trained in basic echocardiography could use the ME4 chamber, 2-chamber, and LAX views for a more comprehensive evaluation of the left ventricle and for monitoring both global and regional LV function. And here's a patient with severe dysfunction of the left ventricle. We felt it was also important that an individual could determine regional wall motion abnormalities, at least with echocardiography, and so we included a nice map of coronary distribution in the manuscript. Now, we had a lot of individuals, at least across the United States and North America, using basic echo for evaluation of the right ventricle, specifically in patients with refractory hypertension and those that were at high risk for RV dysfunction. So we thought that was a reasonable indication as well. Hypovolemia is probably what we use it the most for as anesthesiologist. And it's also a wonderful tool for monitoring the response to fluid and blood component therapy. So we get a little controversial when we talk about basic valvular lesions in particular. And so, again, we thought it was important that somebody could identify both regurgitation and stenosis. But if you needed to quantify it, how severe it is, we felt that was more in the domain of an expert echocardiographer. And then pulmonary embolism, really looking for signs of right ventricular strain. Occasionally you see a clot, such as in the right ventricle of the pulmonary artery. And neurosurgery for air embolism. At least in the States, we don't do a lot of sitting cranies anymore. But TE is very useful in that setting. And then finally, pericardial effusions and thoracic trauma. So I'm going to end here, and I thank you for the opportunity to be here today, and thank you so much.